parts of this innovative technique. The number one, we have replaced the trocar and protective sleeve of a special instrument set with the trocar and protective sleeve of PFN set, which is present in our OT. And number two, we have eliminated the jig portion of the special instrument set and did both proximal as well as distal locking by freehand technique. And number three, we have added a color-coded tibial and extractor or more improved version of the color-coded tibial and extractor for RCT nail introducer compositioner to introduce the nail inside the intermedullary canal in proper position. So the three changes makes this innovative technique as a very, very cost-effective way of doing suprapatellar nailing of tibia. So friends, this is not a Jogaru technique. This has very strong mathematical or scientific basis. After jumping so many steps of mathematical equation, we have come to know that the success of interlocking nailing is equal to K into C into P into Z. Whereas K is the expertise in the art of the freehand technique of locking, whereas the C, P and Z are the respectively the availability of the C arm in your OT and protective sleeve in your special instrument set and jig in your special instrument set. If you increase the value of K to such an extent that the Z becomes zero, that is dependence on the jig becomes zero, this creates a scenario where the surgeon has mastered the freehand technique of locking and can perform both proximal as well as distal locking without the jig. So this is the mathematical basis. We conducted a study between March 20 to March 22-5 on 100 cases of non-articular fracture of the tibia done by Dr. Thakur innovative technique of suprapatellar nailing of tibia. So along with the other instruments, we had two pilot instruments. Number one, a color-coded tibial and extractor, which is present in infrapatellar nailing set, and the more improved version of the color-coded tibial and extractor called RCT nail introducer compositioner to introduce the nail. This is the skin incision, you can see the transverse incision has been given, but you can give vertical incision also. And this is the innovative part of this innovative. Second picture shows the innovative part of this innovative technique, the introduction of the trocar and protective sleeve from PFN A2 set inside the retropatellar space. And the third picture shows the innovative part of this innovative technique, that is the proximal locking by freehand technique. So after making a hole just medial to the lateral tibial spine, we introduce a variable guide wire. After percutaneous reduction of the fracture with the percutaneous forceps, and after serial leadingly, we mounted a appropriate size nail over the color-coded tibial and extractor or RCT nail introducer compositioner, and finally we introduced the proximal as well as distal locking by freehand technique. So this is the flow diagram, nothing to repeat it again, and this is the post-operative follow-up steps. Again, you all are aware of this. This is same as the infrapatellar nailing of tibia. No patient complain of knee pain in our series. All patients get full range of movement in our series by 16 weeks. At final follow-up, 84 cases found excellent results, whereas 30 had good results, whereas 2 had subacute infection at the screw site and 1 had infected non-union. The average time of union was 80 plus minus 10 minutes, whereas average fluoroscopic time was 38.5 plus minus 6.5 seconds. All patients followed 2, 3, 6, 8 and 12 weeks, and the average time of the union was 8 weeks post-surgery, whereas complete union occurred by 12 weeks in all our cases. These are the few cases, clinical and radiological pictures of the few cases done by Dr. Thakur innovative technique of suprapatellar nailing of tibia. So the number of studies done on this innovative technique is small. I think this is the only study done by me, although good number of patients were included. The study was not comparative with the standard technique, so a status of cartilage over the patella and the trochlea was not evaluated in this study. Those furthermore studies required to compare this innovative technique. We had a high-tech presentation in IOACON and found a space in International Journal of Orthopedic Sciences. You can see, and this is a video we don't have time to show you. So the take-home message is this technique would prove a boon for small and medium-class hospitals situated in BSC Great Town in India and poor countries like Bhutan, Nepal and Bangladesh, where the allocation towards the health is very, very low. So this could prove also a very useful technique for Ayushman Bharat Yojana, which is the dream project of our Prime Minister, Shri Narendra Modi. Thank you very much for patient hearing. What are the innovative parts of this innovative technique? The number one, we have replaced the trocar and protective sleeve of a special instrument set with the trocar and protective sleeve of BFN set, which is present in our OT. And number two, we have eliminated the Jeep portion of the special instrument set.
Choose from thousands of realistic voices to use in your content. Change the way you record podcasts.
The digital teaching that the 99.99% of these cases unites without any significant deformity and without any significant functional impairment. But later on, it was found that there are severely displaced fractures, severely comminuted fractures. About 15% of cases require surgical treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense nailing is unlike preservative management. It provides stable fixation and early mobilization and reduces the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage and fewer potential complications, making it an attractive option for managing displaced fraction of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, road traffic accident was the main mode of the trauma, whereas fall from height and fall on out the state hand was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI, and this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin, and this is the radiological typical presentation, more than 2.5 centimeter displacement, and the jet type of cognition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and a screw. So these are the already explained. The simple fracture were taken into consideration. Displaced simple fractures, either spiral or oblique or transverse or short oblique, 15D1 and D2. The patient lies defined with the affected lip elevated and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the abduction of the fracture by closed width. The incision is small incision and a transverse or longitudinal incision about 1 to 1.5 centimeters, just lateral to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of and then we make it hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use tips and grips to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate post of pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, at 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bifurcation, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nail, beautiful surgery without use of any instrument. The reduction has been done by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of 15B1 fracture treated by titanium elastic nailing, yet another case of 15B1 fracture treated by titanium elastic nailing. These are the 15B2 fracture, this is 15B3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see the 6-month follow-up. The beautiful radiological union. This is the functional result. You can see so the time is less. So the limitation of this surgery is a small number of cases included in this case. In this study, so the short follow-up period and retrospective design, so a study with large number of population and long duration of follow-up, and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture of the take-home message is tense nailing is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science.
रस्तोगी जब रैपिडो पे टाइम से पहले ऑफिस पहुंचने लगा तो अपने आप को एकदम टॉप मैनेजमेंट समझने लगा।
17 years old man, the road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a gallaging fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex oral fracture and dislocation, which we call the gallaging fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture of a 17-year-old gentleman, and the forearm gallaging fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this gallaging fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and with a slight distraction, the tense nailing for gallaging fracture. And this is not reported in any literature. For such a severely displaced fracture, the tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of gallaging fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive, and whereas in this left radius, the gallaging fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tension, still there is distraction at the fracture site. So this was the problem with this due to the narrow canal, but this is a 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for the fracture. So, but I left it and wait for it. This is the 8-month follow-up. Still there was better union than 6 months. But this was not hypertrophic, and this is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense spelling provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained and DR, UJ should be reduced properly. We followed the throughout 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirms that interlocking nailing of femur and TENS aids higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did TENS. So this case was published in International Journal of Orthopedic Sciences.
एक मार्ट साहब पटना में एक स्कूल चलाते हैं, गुरुकुल।
मैं उनका वो एकलव्य हूँ जिसने उन्हें अंगूठा काट के देने से इनकार कर दिया। वो हमारा तरफ का इतना बनेगा, गुरु दक्षिणा देना।
दोनों की शादी में सेम फोटोग्राफर था, सेम एल्बम बनाई, पर आज उसकी एल्बम में गोवा की फोटोज है और मेरी एल्बम में सिर्फ शादी की पुरानी फोटोज। क्यों? सिर्फ हस्बैंड की सैलरी का फर्क। मेरा नाम पूजा है, सूरत से। मेरी और मेरी बेस्ट फ्रेंड मीरा की शादी सेम ईयर में हुई, 2022 में। मीरा की शादी एक डॉक्टर से हुई, सैलरी 5 लाख रुपए। मेरी शादी एक प्राइवेट कंपनी वाले से, सैलरी 22,000 रुपए। पहले 6 महीने एडजस्ट कर रही थी, पर धीरे धीरे डिफरेंस समझ आने लगा। मीरा कहती 5,000 का सूट लिया, 5 स्टार में गए। मैं सब्जी खरीदने के लिए भी हस्बैंड से पूछना पड़ता, सब्जी लेनी है 30 रुपए दे दो। उसके घर गई, 50 इंच का टीवी, एसी, मॉड्यूलर किचन। मेरे घर पे पंखा भी नहीं चलता, बिजली का बिल जो बढ़ जाता था। सबसे बुरा, मीरा को ताने नहीं सुनने पड़ते। उसकी सास कहती बेटा जो चाहिए ले लो, डॉक्टर की बहू हो। मेरी सास इतना पानी क्यों यूज किया, लाइट क्यों जलाई, 50 रुपए की क्रीम की क्या जरूरत थी। हर महीने हस्बैंड टेंशन में रहते। खर्चा 18,000 रुपए, सैलरी 22,000 रुपए, कैसे चलेगा। एक दिन मीरा ने कॉल किया, मुझे हस्बैंड ने बर्थडे एक नई कार गिफ्ट करी है। उस रात नींद नहीं आई, सोचा मेरी किस्मत खराब है क्या, पर फिर बोला खुद से, पूजा तू भी पढ़ी लिखी है, तू भी कुछ कर सकती है। नेक्स्ट डे सीखो ऐप का ऐड देखा, पार्ट टाइम काम करके एक्स्ट्रा कमाओ, डाउनलोड किया। पार्ट टाइम इनकम सेक्शन खोला, 15 मिनट की वीडियो देखी, घर बैठे पार्ट टाइम से पैसे कैसे कमाए। नेक्स्ट डे 2 घंटे निकाले और ट्राई किया। शाम को यूपीआई नोटिफिकेशन, 280 रुपए क्रेडिटेड। विश्वास नहीं हुआ, मैंने सिर्फ 2 घंटे में कमाया बिना किसी से पूछे। रोज रात को 11 बजे से सीखो टाइम बन गया। पहले हफ्ते 800 रुपए, दूसरे हफ्ते 2000 रुपए, तीसरे हफ्ते या 3500 रुपए, एक महीने में 10,000 रुपए कॉन्स्टेंटली आने लगे। पहली बार अपने पैसे से क्रीम ली, साड़ी ली, किसी से नहीं पूछा। हस्बैंड ने कहा प्राउड फील हो रहा है। सास ने अकाउंट स्टेटमेंट देखा, 10,000 रुपए मंथली। एटीट्यूड बदल गया, बेटा अच्छा कर रही हो, पार्ट टाइम से भी इतना आ सकता है। आज 8 महीने हो गए, महीने का 18,000 रुपए कॉन्स्टेंटली कमाती हूँ। पर मेरी कहानी यहाँ खत्म नहीं हुई। सीखो ऐप की असली ताकत तो मैंने आगे जाकर देखी। 10,000 रुपए आने लगे तो कॉन्फिडेंस आया। सोचा और क्या सीख सकती हूँ। सबसे पहले एस्ट्रोलॉजी सेक्शन खोला। याद है मैंने सोचा था मेरी किस्मत खराब है क्या, पहले लगता था मेरी किस्मत ही खराब है, ग्रहों ने साथ छोड़ दिया। पर वहाँ अपनी कुंडली समझी और अपने ग्रहों के हिसाब से उपाय किए। मन का बोझ हल्का हुआ, रात को नींद आने लगी, काम सही होने लगे और अपने ऊपर विश्वास बढ़ा। फिर इंग्लिश सीखो सेक्शन खोला। सोचा अगर इंग्लिश आ गई तो ऑनलाइन काम और बढ़ सकता है, बेटर क्लाइंट्स मिल सकते हैं। रोज 15 मिनट प्रैक्टिस की। आज कॉन्फिडेंटली ईमेल्स लिखती हूँ, वीडियो कॉल्स पे बात करती हूँ। मेरी रेट्स पहले से डबल हो गई हैं। फिर करियर ग्रोथ सेक्शन देखा, वहाँ फ्रीलांसिंग के एडवांस्ड स्किल्स सीखे, कंटेंट राइटिंग, सोशल मीडिया हैंडलिंग। अब सिर्फ पार्ट टाइम नहीं, मल्टीपल इनकम सोर्सेज है। इनकम स्टेबल हो गई, पैसा बढ़ने लगा तो शेयर मार्केट सेक्शन खोला। पहले लगता था शेयर मार्केट तो अमीर लोगों का काम है, पर वहाँ सीखा कि 500 रुपए से भी इन्वेस्ट कर सकते हैं। हर महीने अपनी कमाई का थोड़ा इन्वेस्ट करती हूँ। बच्चों के फ्यूचर के लिए कॉर्पस बन रहा है। और सबसे जरूरी फाइनेंस सेक्शन से बजट बनाना सीखा। पहले पैसा आता था, पता नहीं कहाँ जाता था। अब प्रॉपर सिस्टम है, कितना घर के लिए, कितना अपने लिए, कितना इन्वेस्ट करना है। हस्बैंड भी इम्प्रेस्ड है, कहते हैं तू तो फाइनेंशियल एडवाइजर बन गई। एक ऐप ने मुझे पार्ट टाइम इनकम, एस्ट्रोलॉजी गाइडेंस, इंग्लिश कम्युनिकेशन, करियर ग्रोथ स्किल्स, शेयर मार्केट इन्वेस्टिंग और फाइनेंशियल मैनेजमेंट सब कुछ एक जगह से सिखा दिया। मीरा के पास आज भी हस्बैंड की सैलरी है, मेरे पास अपनी मेहनत की कमाई है, अपने ऊपर विश्वास है और फ्यूचर प्लान है। और वो फीलिंग अलग है। घर का खर्चा कंट्रीब्यूट करती हूँ, सास रिस्पेक्ट से बात करती है, हस्बैंड प्राउड फील करता है। मैं किसी से कंपेयर नहीं करती क्योंकि मैं भी फाइनेंशियली इंडिपेंडेंट हूँ। डॉक्टर से शादी नहीं हुई तो क्या, मैंने अपने पार्ट टाइम को फुल टाइम इनकम बना लिया। अगर तुम भी ससुराल में इज्जत चाहती हो या अपनी पहचान बनाना चाहती हो, इंस्टॉल नाउ दबाओ, पार्ट टाइम इनकम सेक्शन खोलो। सीखो से सीखोगी तो ही बढ़ोगी।
तो इंस्टॉल बटन पे क्लिक करो और सीखो ऐप डाउनलोड करो।
Provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. Hence, is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years, and no comorbidity was found in our study group. All patients treated with titanium elastic nylon. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of communicated fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. The 15B1 is a spiral and oblique, whereas 15B2 is the transverse and short fracture. So the patient lies supine with affected limb elevated and hanging outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is the very crucial step, and then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb after 2 weeks, the wound inspection and the suture removal after 6 weeks, the regular follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6-month final follow-up was 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 60% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite out, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the 1ST surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did, the 15B1 fracture treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. One bump is due to secondary callus formation, and other at the entry site you can see that there is hardware prominence. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case, 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with a plate and a screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small, and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS nailing is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patient hearing.
You know just one clean, perfect shot, how difficult it is to take? Well, let's fix this in seconds. With Canva's Magic Eraser, removing distractions is the easiest task. Just tap on what you want to erase and voila, the photobomb is gone, leaving you with a flawless picture. And the best part, there's no need for pricey apps or complicated edits. Just one tap with Canva's Magic Eraser. Finally, a picture worth posting, no distraction, just perfection.
ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटलर नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। हम नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल तक डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है आरसीटी नेल इंट्रोड्यूसर कंपोजिटर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सी आर्म के मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से सी आर्म को एडजस्ट किया जाता है कि होल गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है। अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है। नेल को और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से CR को एडजस्ट किया जाता है कि वो गोल दिखे। और एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से CR एडजस्ट किया गया है। और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है। और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए। छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैगमेंट फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo of interlocking nailing in fractured shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the shaft femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blunt dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intramedullary canal
so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the every view. It has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3, at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide line is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we remove this bone out, and then after reduction of the fracture with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal fragment. And after introduction of the guide wire, we are going to ring the medullary canal with the help of 9 millimeter ring off, and it is being rimmed with 9 millimeter ring off, hand ring off. And across the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During nailing process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. And I am doing reaming with a 10 millimeter reamer, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in amplitude, and also in lateral view. the oblique view. And after performing in the CR in both views, we did drilling up to the lower end of the femur, and finally we removed this fracture with the help of power ream of 11 millimeter. Because the patient is old one, so reaming is easy. It is just to measure the size of the intermedullary canal, the diameter of the intermedullary canal, so what size of the nail should be introduced so that it can fit in the intermedullary canal. The fitting nail can be introduced. So this is the purpose of reading. Because the patient is old one osteoporotic, throughout the nailing process, reaming process and nailing process, the fracture is kept in reduced position by my assistant, and the fracture has been linked up to the lower upper end of the patella, as you can see in the CR picture. You can see in the CR picture it is reduced, although there is slightly distracted, but in reduced position. And finally, it has reached up to the lower end of the femur. And now I am measuring the size of the nail with the help of the CR. And after selecting the proper size of the nail, I have mounted a 10 millimeter, a 11 millimeter, 11 millimeter nail on cheek, and finally I am hammering the nail inside the intermedullary canal and keeping the fracture in reduced position with the help of my assistant, so that the malalignment can be prevented. And finally, I have introduced the appropriate size nail up to the upper pole of the patella. It is good position, the fracture is reduced in both view, in the oblique view and lefty view and lateral view. And when I will remove the guide wire before proximal locking, and now I am doing proximal locking after removal of the guide wire. So you must keep in mind that before locking you have to remove the guide wire. And I am doing proximal locking. The proximal hole in the proximal fragment the near cortex is perforated with the help of 2.5 millimeter K wire and the distant cortex is drilled with 3.2 millimeter drill bit, and finally we select a proper size 5 millimeter screw for proximal locking, and I am still making a hole in the distal fragment, distal cortex, and now I am tightening the screw, the second screw in the proximal fragment. As you can see in the CR picture, the proper size screw has been tightened in proper position, and it is confirmed that it is inside the hole in both AP and lateral view. And now I will do the distal locking by freehand technique. I will make the hole circular after adjusting the CR in lateral position, and I am tightening the screw after drilling with 3.2 millimeter drill bit. As you can see in this picture, and both the screws have been tightened and confirmed in AP and lateral view. The size of the screw is confirmed in the AP view, and whether it is inside the hole or not, it is confirmed in lateral view. The size of the screw is slightly larger than it should be, but it was accepted because the effect of anesthesia was wearing off. So it was accepted, and you can see that both in the AP and lateral view, the both proximal angle and the distal screw are in place and in proper position. And now I am going to close the wound after forceful wash of the wound so that all the... Now I am closing the wound after forceful wash of the wound. Now the wound has been closed. And the surgery is over. So thank you to my assistant, my anesthetist, and all the supporting staff for successful surgery of this 72 years old female for fracture sharp femur, which had been operated on the other side elsewhere 4 years back. So this is on the whole a successful and well-executed surgery. Thank you. Hello friends, I am Dr. R.C. Thakur, orthopedic surgeon, Sapra, Bihar. Today I will give a demo of PFN A2 surgery for an osteoporotic patient for intertrochanteric fracture of the femur. The design of the spiral blade provides a stable fixation of this fracture and you can make mobile our patient. So today let us come to the surgery. This is the X-ray of 72 years male having osteoporosis with a fracture of the intertrochanteric on a stable type. And this is the post-operative X-ray of the same patient. And now I am going to start my surgery. The skin incision, before the skin incision, I will draw a line from anterior superior iliac spine down to the table, and another line from the tip of the greater trochanter towards this first line, and the point of bisection of these two lines is the point of incision for this surgery. So I am making an incision at these bisecting points where the two lines bisect. So I am giving incision about 2 centimeters, as you can see in the picture. So I am feeling the correct point of entry. It should be at the junction of the anterior 2/3 and posterior 1/3 in lateral view, and in epi view it is just medial to the greater trochanter in the piriform fossa. So I am feeling with my fingers the correct entry point. So after feeling this, I am confirming, I am introducing a bone owl at the correct point selected, and then I am confirming this whether this bone owl is entering at correct selected point or not in C-arm picture. So I am introducing the owl in correct position after confirming the entry point in C-arm picture, both in epi and lateral view. So this is the epi view. It is entering in proper selected position, and this is inside the intramedullary canal in correct position, going medially in epi view, and this is hammered if it is in place inside the intramedullary canal in proper position, confirming in both epi and lateral view. And then I will pull this bone out for 2 centimeters to introduce the guide wire. millimeter to introduce the guide wire. The depression or groove present in the lateral side will guide this guide wire inside the hole, and the guide wire is entering inside the intramedullary canal along the depression or groove present laterally in the owl. So it is inside the intramedullary canal, well placed in FP view. And now I will remove the owl. So I have removed the owl, and I'm doing reading of the medullary canal. In the osteoporotic patient, the reading is not required. This is for the measuring the size of the intramedullary canal, diameter of the intramedullary canal, to select the correct size of the PFN to nail. So, but this is for measuring the intramedullary canal, and I am reading by number 10 and then number 11, remove, and the size is 11 millimeter diameter, PFN nail selected, and then I am reading with a 15 millimeter reamer because the upper part of the nail is about 15 millimeter diameter. So I am reading this, and my assistant is pushing the reamer sleeve medially so that it goes in correct position. So it has been aimed with 15 millimeter reamer, and now I am introducing the nail of selected size, and I will hammer the reamer with the help of supine. Drive. I am hammering the nail inside the intramedullary canal so that the hole present in the nail comes in the central position of the neck of the femur in AP view, and the spiral blade can be introduced in central position in every view. And now I am giving an incision for introduction of the spiral blade, and this is the buttress nut. My assistant is tightening it, and so that it touches the lateral wall of the femur. And then I will introduce a guide wire sleeve, and a hard and a stout guide wire is being hammered in the central position of the neck of the femur. And I'm confirming it whether it has gone in central position in both AP and lateral view. You can see in the picture, it is in very good place. It is central in AP view and central in lateral view also. So I am doing rimming. Some surgeons do rimming up to the lateral cortex only, but I do rimming up to the size of the nail selected. So I have rimmed up to the proper distance, and now I am hammering the spiral blade after confirming it central position in both views. And I am compressing this spiral blade by clockwise movement, and so I am compressing the spiral blade by clockwise movement and removing the screwdriver by anti-clockwise movement. So the spiral blade is introduced in proper position, both anterior and lateral view, and then my assistant is attaching the arm for digital locking on the jig. And after measuring the screw size, I am introducing the drill sleeve for drilling the cortex for digital locking. And this is the 2.5 millimeter guide wire. I am introducing, just perforating making a dimple on the lateral cortex. I am hammering this hard and stout guide wire in the lateral cortex. And after confirming it, in CR picture, I am drilling with the power drill, both lateral and the first cortex is drilled, and now second cortex is also drilled. And now I will put a selected size of a screw for digital locking. I am measuring this on the CR. I am measuring the size of and now I am tightening the screw, digital screw. The final tightening is done. So confirming in CR picture. The final tightening is being done now. It has been tightened. And now my surgery is over, and this is the happy view. You can see that it is in good position, and this is the lateral view of digital screw. It has been introduced in proper position in the hole, and this is the lateral view. The spiral blade has gone in the central position in lateral view also. So I will give a forceful wash of the wound, and finally I will stitch the skin and close the wound in layers. And I'm closing the wound. And wound has been closed. Without any drain. And I'll mobilize this patient on second post-operative day. This surgery is well indicated for the osteoporotic patient with an unstable type of intertrochanteric fracture because the very design of the spinal plate provides a stable fixation, and we can mobilize the patient from second post-operative day. So this is the lateral view, and this is the AP view post-operative. So thank you everybody. My anesthetist, my assistant, my supporting staff. I think this is a well-experienced surgery for an old osteoporotic patient, for unstable type of intertrochanteric fracture. We can make this patient mobile from second post-operative day, which is usually required. Although this was not a very distressed fracture, but to make the patient mobile, we planned this surgery for this patient. Thank you everybody.
Hello friends, I am Dr. RCT Thakur, orthopedic surgeon, Chhapra, Bihar. Today I am going to present my innovative work named Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia. Tibial fractures are most common among the long bone fractures in human body.
These are usually caused by high energy trauma like
Fall from height. Study shows Dr. Thakur innovative technique of suprapatellar nailing of tibia is safe, cost-effective method of treatment for metaphyseal tibial fractures. Intramedullary nailing technique is the treatment of choice for diaphyseal fracture of tibia in adults. In treatment of metaphyseal tibial fractures, concerns regarding difficulties with reduction due to anterior deformity becomes a challenge. Suprapatellar nailing becoming popular choice for treating metaphyseal fractures. It is highly specialized surgery and requires very highly specialized instruments, sets and implants that tends to be very costly. Dr. Thakur innovative technique of suprapatellar nailing of tibia delivers 100% satisfactory union of fracture in safe and cost-effective way. No special instrument or jig are required. A protective slip and a trocar can be used from PFN A to Z, and color-coded infrapatellar tibial nail extractor can be used to introduce the nail in proper position. Between March 2020 to March 2021, Dr. Thakur innovative technique of suprapatellar nailing of tibia conducted on 25 patients to fix their tibial fractures. The patients having tibial fractures with no involvement of articular surface were included in this study. Age of the patient ranged between 18 to 60 years and they had no comorbidities. All surgery were performed
2.5 millimeter K wire used as a blocking wire to improve nailing of proximal tibial fractures. The tibial fractures of all the patients was fixed by Dr. Thakur innovative technique of suprapatellar nailing of tibia. This is the flow diagram how Dr. Thakur innovative technique of suprapatellar nailing of tibia done. It is done in semi-extended position, about 20 degree of flexion at the knee joint, either transverse or longitudinal skin incision we are given, but longitudinal split of quadricep tendon done. Knee joint entered from above, proper and protective sleeve from PFNA to set inserted. Entry point is just medial to the lateral tibial spine. The guide wire, first malleable guide wire, were introduced after severe bleeding, fracture reduction, and confirmed by fluoroscopy, mounting of the nail with appropriate size over the color-coded tibial nail extractor done. Introduction of appropriate nail size over the guide wire done in proper position with the help of color-coded tibial nail extractor. Locking both proximal and distal done by freehand technique. No jig were used. Wash and repair of quadricep tendon done and closure done. These are the pictures how we did our cases by Dr. Thakur innovative technique. These are the instruments, the color-coded tibial nail extractor, protective sleeve from PF and A to set, trocar and malleable guide wire, and stout and hard guide wire. Reamer, these are the passage of sleeve, trocar and hard guide wire in the retropatellar space in AP and lateral view. Passage of reamer over the guide wire after percutaneous reduction with the reduction forceps in AP view, and this is in lateral view. Nail entry over the guide wire and nail entry in distal fragment in AP view. Nail entry in distal fragment in lateral view, and then both locking screw introduced in proximal fragment. In AP and lateral view, all the three screws introduced in distal fragment by freehand technique. This is the clinical picture. Proximal locking done by freehand technique. Post-operative follow-up steps. First post-operative day, passive flexion and extension. flexion and extension at the knee joint and ankle joint. The 10th post-operative day, patient started walking with the help of walker, non-weight bearing. 6 to 8 weeks post-op, we started partial weight bearing. 12 weeks after operation, we started full weight bearing. Now, the final observation, operative time was in this study 80 plus minus 10 minutes. Range was 65 to 110 minutes. Average fluoroscopy during surgery was 38.5 plus minus 6.5 seconds. The range being 10 to 50 seconds. The average time of union fracture was 8 weeks after surgery, with fracture healing time was 12 weeks. Average hospital stay was 10 to 12 days. All patients followed up after 2, 3, 6 and 12 weeks. Those who could not return for follow-up, telephonic follow-ups were done and called for follow-up in hospital. No complication were observed. No patient experienced any loosening or breakage of a screw or nail. No one complained of knee pain. No reduction loss or significant displacement of fracture occurred after surgery. At final follow-up, 21 cases found excellent and 4 good results. In none of the patient, removal of nail was done for any cause. These are the results. Fracture, lower third tibia, APL lateral view, post-op X-ray of lower third tibia, APL lateral view. Fractures, lower third tibia, again second case, APL lateral view, post-op X-ray picture, APL lateral view. This is third case of fracture of upper third tibial fractures, APL lateral view, post-op, and this is the clinical pictures, 3 weeks follow-up. Okay. Fourth case, pre-op X-ray, upper metaphyseal fracture of tibia, and this is the post-op X-ray of upper third fracture of metaphyseal tibia. This is fifth case, the lower third, very low fracture of tibia, and this is the post-op APL lateral view. This is the clinical picture 3 weeks after the surgery. Duration of this surgery, the number of patients included in this study was small. The study was not comparative with the standard technique. The status of cartilage over the patella and trochlea post-surgery has not been evaluated. Thus, furthermore study with larger population and long follow-up time is required to compare this innovative technique with a standard technique of suprapatellar nailing. In this technique, fluoroscopy time was slightly more than the standard technique because both distal and proximal locking were done by freehand technique. Finally, friends, this innovative technique is very cost effective. In fact, no cost is incurred for this suprapatellar technique. Whereas the standard instrument sets are very costly, this technique can be adopted in smaller and medium class orthopedic hospital. If the only disadvantage of this technique is the slightly more radiation occurs because the locking both proximal and distal are done with free hand technique. But this can be lessened by gaining more and more experience in free hand technique for locking proximal and distal tibia. Thank you. The number one myth is interlocking nailing of humerus will severely impair the shoulder function due to rotator cuff damage. The reality is, with proper technique and entry point, the rotator cuff damage can be minimized and shoulder function can be preserved. So the myth number two is there is always chance of radial nerve injury as it is a complication for the interlocking nailing of humerus. It is not a complication for the open reduction and internal fixation for plating. So it is, yes, it is, there is risk of radial nerve injury when the fracture is at the spiral groove. There is chance of the radial nerve injury, but in the rest of the part, if the fracture is in the rest of the part of the humerus, there is minimum chance of the radial nerve injury when the instruments like the guide wire, remote, and the nail is introduced after proper reduction of the fracture in the distal fragment. Both AP and lateral view, the fracture is reduced properly. Only then these instruments are introduced inside the distal fragment. And don't allow your instrument to wander inside the soft tissue. So these are the two myths which is associated with interlocking nailing of humerus, and other two controversies whether which position of the patient should be used for the interlocking nailing of humerus. There are three positions. Number one, supine position. When it is used, it is comfortable for the anesthesia point of view as well as the surgeons. But the distal locking, which is done by freehand technique, is slightly difficult and tricky because the anterior surface of the distal part of the humerus is triangular. So finding the entry point for the distal locking is slightly difficult because slipping of the drill bit or KY. So it should be at angle, it should be introduced at angle, and then it should be kept in a straight line. So this is the disadvantage of supine position, and in lateral position as well as the prone position, the distal locking is done from the posterior surface, which is flat. So the entry hole, finding the entry point for the distal locking is easy because the surface is the flat, but it is uncomfortable position for anesthesia point of view, and the surgeons, it depends on the surgeon's choice. So I do use supine position for all my interlocking nailing. Number three controversy is because it is non-weight bearing bone, so one screw distal and one screw proximal is sufficient. But I use 2 screw distal and 2 screw proximal because the 2 is always better than 1, always stronger than 1. If it is just like the 2 kidney present in human body, if one fails, others start working. So, and 2 engines in the aeroplane, one engine fails, the other start working automatically. So if one screw is not working, then the other screw will do its work. So the fixation is better by 2 screw proximal and 2 screw distal. So friends, these are the advantages of locking nailing over the plating of the humerus, and these are the myths, and these are the controversies whether 2 screws should be put proximal as well as the distal, what position should be used in this talk, and let us get tuned for the next video and subscribe my channel for more update on orthopedic surgery and insight.
Ready to level up your content? Generate high-quality, human-like voiceovers in seconds with 11 Labs. Perfect for videos, games, articles.
ये है मिस्टर प्रशांत कुमार जो असम से आए हैं। उनके दाहिने कूल्हे का एक्सरे पिक्चर जैसा कि आप देख सकते हैं काफ़ी डिफॉर्म्ड हो गया है और एक दूसरे में चिपक गया है। कूल्हे का हड्डी, कूल्हे का गोला कप में चिपक गया है और काफ़ी हड्डी बन गया है। उनके इसके कारण काफ़ी रेस्ट्रिक्शन मूवमेंट में उनको हो रहा था। वे ठीक से बैठ भी नहीं पाते थे कुर्सी पर। ये है एक्सरे पिक्चर, जिन्हें टोटल कूल्हा उनका बदल दिया गया है ऑर्थो सर्जिकल केयर सेंटर में। और 10 दिन के बाद वो वॉकर पे चल रहे हैं और फिर सीढ़ियों से उतर रहे हैं। इसमें ध्यान ये रखना पड़ता है कि उतरते समय पहले प्रेशर वाले पैर कूल्हा को बदला गया है, उसको पैर रखना, उस पैर को रखना है। उसके बाद अच्छे पैर को रखना है और चढ़ते समय पहले अच्छे पैर को ऊपर रखना है। उसके बाद जिसमें कूल्हा को बदला गया है उसको रखना है। ये अब ऑपरेशन के बाद ये कुर्सी पर बैठ सकते हैं, इवन लो चेयर्स पे भी बैठ सकते हैं और काफ़ी कंफर्टेबल और पेनलेस मूवमेंट ऑफ नी जॉइंट आप देख सकते हैं किस तरह से खुद खड़े हो जा रहे हैं और लो चेयर पर भी आराम से बैठ जा रहे हैं। ये बिना सहारा के 10वें दिन बिना दर्द के चल पा रहे हैं।
छपरा के डॉक्टर आरसी ठाकुर ने हड्डी फ्रैक्चर के इलाज में क्रांतिकारी तकनीक विकसित कर देश भर में पहचान बनाई है। उनकी तकनीक से 35 लाख रुपए तक का महंगा इलाज मात्र 35,000 में संभव हो सका है। ऑर्थो सर्जरी में योगदान के लिए गुवाहाटी में आयोजित इंडियन ऑर्थोपेडिक एसोसिएशन के राष्ट्रीय सम्मेलन में उन्हें इनोवेशन अवार्ड से सम्मानित किया गया। यह उपलब्धि छपरा, सारण और बिहार के लिए गर्व की बात है।
इनोवेशन अवार्ड इंडियन ऑर्थोपेडिक एसोसिएशन द्वारा शुरू किया गया है, जो कि गुवाहाटी IOA 25 में दिया गया है। और यह अवार्ड पूरा भारतवर्ष में 3 ऑर्थोपेडिक सर्जन को मिला है, जिसमें बिहार से मेरा ही नाम है। अतः से छपरा जिला में जिला का कोई ऑर्थोपेडिक सर्जन या बिहार का कोई ऑर्थोपेडिक सर्जन को पहले बार सौभाग्य प्राप्त हुआ है, जिसमें मेरा नाम आया है।
of this innovative technique. The number one, we have replaced the trocar and protective sleeve of a special instrument set with the trocar and protective sleeve of PFN L2 set, which is present in our OT. And number two, we have eliminated the jig portion of the special instrument set and did both proximal as well as distal locking by freehand technique. And number three, we have added a color-coded TBL and extractor or more improved version of the color-coded TBL and extractor for RCT nail introducer compositioner to introduce the nail inside the intermedullary canal in proper position. So these three changes makes this innovative technique as a very, very cost-effective way of doing suprapatellar nailing of tibia. So friends, this is not a Jogaru technique. This has very strong mathematical or scientific basis. After jumping so many steps of mathematical equation, we had come to know that the success of interlocking nailing is equal to K into C into P into Z. Whereas here is the expertise in the art of the freehand technique of locking, whereas the C, P and Z are the respectively the availability of the C arm in your OT and protective sleeve in your special instrument set and jig in your special instrument set. If you increase the value of K to such an extent that the Z becomes zero, that is dependence on the jig becomes zero, this creates a scenario where the surgeon has mastered the freehand technique of locking and can perform both proximal as well as distal locking without the jig. So this is the mathematical basis. So we conducted a study between March 20 to March 22 5 on 100 cases of non-articular fracture of the tibia done by Dr. Thakur innovative technique of suprapatellar nailing of tibia. So along with the other instruments, we had two pilot instruments. Number one, a color-coded tibial nail extractor, which is present in infrapatellar nailing set, and a more improved version of the color-coded tibial nail extractor called RCT nail introducer compositioner to introduce the nail. This is the skin incision. You can see the transverse incision has been given, but you can give vertical incision also. And this is the innovative part of this innovative. Second picture shows the innovative part of this innovative technique, the introduction of the trocar and protective sleeve from PFN A2 set inside the retropatellar space. And the third picture shows the innovative part of this innovative technique, that is the proximal locking by freehand technique. So after making a hole just medial to the lateral tibial spine, we introduce a malleable guide wire. After percutaneous reduction of the fracture with the percutaneous forceps, and after serial leadingly, we mounted a appropriate size nail over the color-coded tibial nail extractor or RCT nail introducer compositioner, and finally we introduced the proximal as well as distal locking by freehand technique. So this is the flow diagram, nothing to repeat it again, and this is the post-operative follow-up steps. Again, you all are aware of this. This is same as the infrapatellar nailing of tibia. No patient complained of knee pain in our series. All patients gained full range of movement in our series by 16 weeks. At final follow-up, 84 cases found excellent results, whereas 30 had good results, whereas 2 had subacute infection at the screw site and 1 had infected non-union. The average time of union was 80 plus minus 10 minutes, whereas average fluoroscopy time was 38.5 plus minus 6.5 seconds. All patients followed 2, 3, 6, 8 and 12 weeks, and the average time of the union was 8 weeks post-surgery, whereas complete union occurred by 12 weeks in all our cases. These are the few cases, clinical as well as radiological pictures of the few cases done by Dr. Thakur innovative technique of suprapatellar nailing of tibia. So the number of studies done on this innovative technique is small. I think this is the only study done by me, although good number of patients were included. The study was not comparative with the standard technique, so a status of cartilage over the pipeline trachea was not evaluated in this study. There was furthermore studies required to compare this innovative technique. We had a high-tech presentation in IOACON and found a space in International Journal of Orthopedic Sciences. You can see, and this is a video we don't have time to show you. So the take-home message is this technique could prove a boon for small and medium-class hospitals situated in BSC Great Town in India and poor countries like Bhutan, Nepal and Bangladesh, where the allocation towards the health is very, very low. So this could prove also a very useful technique for Ayushman Bharat Yojana, which is the dream project of our Prime Minister, Shri Narendra Modi. Thank you very much for patient hearing. The traditional teaching that the 99.99% of these cases unites without any significant deformity and without any significant functional impairment. But later on, it was found that there are severely displaced fractures, severely comminuted fractures. About 15% of cases require surgical treatment either in the form of tense snelling or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense snelling is unlike conservative management. It provides stable fixation and early mobilization and reduces the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage and fewer potential complications, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, or were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic snelling in my hospital. So the mode of trauma, road traffic accident was the main mode of the trauma, whereas fall from height and fall on outer state side was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI, and this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin, and this is the radiological typical presentation, more than 2.5 centimeter displacement, and the jet type of condition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and screw. So these are already explained. The simple fracture were taken into consideration. Displaced simple fractures either spiral or oblique or transverse or short oblique, 15D1 and D2. The patient lies supine on a affected lip, elevated, and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the reduction of the fracture by closed width. The incision, small incision, has a transverse or longitudinal incision about 1 to 1.5 centimeters, just lateral to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense snelling after close reduction or mini incision reduction. So the immediate post of pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, and 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bite out, superficial infection, and the malunion each were 4%,
whereas hardware radiation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic technique, beautiful surgery without use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery, and this is the